Hello and welcome back to this channel. My name is Mr. Abbas Saglobi. So if you are new, kindly subscribe, hit the notification button so you'll be notified when other contents are dropped. So going straight to what we have today, the first question says, a physician wants to wean a patient or ventilator in the morning. At 6 a.m., the ABG says respiratory acidosis. What would you do next? A physician wants to wean a patient off ventilator in the morning. At 6 a.m., the arterial blood gas says respiratory acidosis. What would you do next? 1 says remove the ventilator as ordered by the doctor. B says notify the doctor that patient is not ready to be weaned off ventilator. 3 says, or what you see, continue to monitor the patient. And D says check the machine if everything is okay. A patient is to be weaned off ventilator at 6 a.m. but the ABG says respiratory acidosis. What is the best thing you are supposed to do? Are you to remove the ventilator as ordered by the patient, by the doctor, or you have to notify the doctor that patient is not ready to be weaned off ventilator, or you have to continue to monitor the ventilator, or you have to check the machine if everything is okay? Let's hold on to number 1 and then move on to number 2. Number 2 says the ICU nurse is caring for a sedated client on the ventilator. The ventilator alarm is beeping persistently for low pressure despite the fact the client is calm and has stable vitals. What is the most appropriate action for the RON to take first? The ICU nurse is caring for a sedated client on the ventilator. The ventilator alarm is beeping consistently for low pressure despite the fact that the client is calm and has stable vitals. What is the most appropriate action for the RON to take first? A. Suction secretion. B. Check the tubing for holes. C. Call respiratory therapy and then continue to monitor the patient or monitor the machine. What are we supposed to do first? Low pressure despite fact that the client is calm and has stable vitals. What are we supposed to do next? Let's hold on and move to number 3. Number 3 says a physician wants to wean a patient off ventilator in the morning. At 6 a.m., the ABG says respiratory alkalosis. Respiratory alkalosis. What would you do next? Respiratory alkalosis is opposite of number 1. But this time is respiratory alkalosis. What are you supposed to do? 1. Remove the ventilator as ordered by the doctor. B. Notify the doctor that patient is not ready to be weaned off ventilator. And C says continue to monitor the patient. And D says check the machine if everything is okay. Now, answering this question require us to understand the rules and regulations that guide ventilator use. So, we are going to move into talking about ventilators and how we're able to know when and what are the first steps to do when it has to do with ventilator. So before I talk about the ventilator itself, let's understand some terms, some terminology we will see under ventilator use. Number 1 among them is what we call peak inspiratory pressure. Peak inspiratory pressure, call it PIP. Peak inspiratory pressure. What is peak respiratory pressure? Now, it is the highest level of pressure in the lung during inhalation. Now, during inspiration, you take in oxygen. Now, that pressure, the highest level of pressure in the lung during inhalation is called peak inspiratory pressure. Peak inspiratory pressure, the highest level of oxygen in the lung during inspiration. Number 2, we have positive end expiratory pressure. Positive end expiratory pressure. What does it mean? The amount of pressure in the alveoli at the end of expiration. The amount of pressure in the alveoli at the end of expiration. Now, let's not forget there's what we call expiratory reserve volume. Expiratory reserve volume. Now, expiratory reserve volume is the amount of air remaining in the lung after expiration. The amount of air remaining in the lung after expiration is called expiratory reserve volume. However, the amount of air remaining in the lung after expiration, called expiratory reserve volume, will exert a pressure. That pressure is what we call positive end expiratory pressure. Positive end expiratory pressure, which we say the amount of pressure in the alveoli at the end of expiration. So number 3, we have what we call fraction of inspired oxygen. Fraction of inspired oxygen, that is FiO2. FiO2, what does it mean? How much oxygen the client is getting. Fraction of inspired oxygen. As the patient is breathing in, how much oxygen the client is taking in is what we call fraction of inspired oxygen, and of course is usually between 21 to 100. Mind you, this is different from SpO2. SpO2 is the amount of air in the blood, saturation in the blood, SpO2. But this one is called fraction of inspired oxygen, how much oxygen the client is getting, and of course between 20 to 100%. Now next we have is tidal volume. What is tidal volume? The amount of air inhaled during one respiratory cycle. The amount of air inhaled during one respiratory cycle. Now when you breathe in, the amount of air that you breathe in, that you have within your lung per respiratory cycle, is what we call tidal volume, TV. Now next we have is end tidal carbon dioxide. End tidal carbon dioxide. Now what does it mean? The partial pressure of CO2 detected at the end of expiration. Now by the time you give out carbon dioxide, now the partial pressure of CO2 that is detected at the end of your expiration is what we call, at the end of exhalation, is what we call end tidal carbon dioxide. So that is what we mean. And of course, the last term to go to talk about is the room air. We call it ROA, room air. What does it mean? It means the atmospheric air we breathe under normal circumstances. So without pressure, without stress, the atmospheric air we breathe in under normal circumstances is what we call room air. And of course, it has a relationship with what we call the fraction of inspired oxygen. Remember, we say how much oxygen the client breathes in, the client is getting. So room air, the amount of oxygen you are getting, is also sometimes referred to as the room air. Why? The atmospheric pressure is what will determine the amount of air you get. So it is the room air that will determine the fraction of inspired oxygen. So these are terms I want us to look at, and before we move on to talking about ventilator, remember we said peak inspiratory pressure, we have the positive end expiratory pressure, we have the fraction of inspired oxygen, and we have the tidal volume, and we have the end carbon dioxide. All of these terms are what we're going to look at as we move on to ventilator. Now the next question is, what is ventilator? What do we need to know about ventilator? So a ventilator is a machine designed to move breathable air in and out of the lungs. A ventilator is a machine designed to move breathable air in and out of the lung. And of course, it aids patients who are physically unable to breathe or having breathing insufficiency, or discover that probably they're having difficulty in breathing or the breathing is never enough. Ventilator is used. So a ventilator is equipped with two kinds of pressure. We call it the high pressure and low pressure alarm. So a ventilator is a machine that is designed to move breathable air in and out of the lung. Of course, like I said, it aids the patient who are physically unable to breathe. And of course, not just inability to breathe, it also helps patients with breathing insufficiency. So it means that for a ventilator to work effectively, it is equipped with two types of alarm. We call it high pressure alarm and low pressure alarm. High pressure alarm and low pressure alarm. The question is this: what does it mean by high pressure alarm? What does it mean? And what does it mean to have low pressure alarm? Now, high pressure alarms are always triggered by increased resistance to airflow. High pressure alarm are always triggered by increased resistance to airflow. Now, what do we mean by increased resistance to airflow? It means that there was an obstruction. For air to flow from the ventilator to the patient, the tubes need to be free. However, if there's an obstruction, the machine is going to push air into the lung under increased resistance. Hence, there's going to be increased high pressure alarm, meaning there's an obstruction somewhere. High pressure alarm, I said they are triggered by increased resistance to airflow. So if you hear high pressure alarm, what should you be looking out for? Check out for obstruction. Check out for obstruction. It means that at that point, it could be that there is kicking of the tube. Are the tube free? If they are not free, if there is kicking of the tube, what do? Unkick the tube. 2, it could be that the obstruction is being caused by condensed water in the tubes. Condensed water from within the tube. So if there is condensed water within the tube, what should you do? Empty the condensed water from the tube. 3, it could be that there is mucus plugs, meaning mucus from the patient probably must have blocked the tube. What should you do at that point? Ask the patient to turn, cough, deep breathe, or what do? You suction the tube. What have I said? If there is mucus plug on the tube, what should you do? Ask the patient to turn. When the patient turns, ask the patient to cough. When the patient coughs, or you could have the patient to deep breathe, have a deep breath. Or what can you do? You can suction the tube to remove the clogged mucus. Remember, high pressure alarm are triggered by increased resistance to airflow. Now, the big question then is, what is the appropriate order? In what order should we take care of high pressure alarm? If we hear high pressure alarm, in what order are we supposed to attend to the patient? Number 1, unkick the tube. 2, empty water from the tubing. 3, turn the patient, ask the patient to cough or take a deep breath. And lastly, you suction. So the steps to attend to high pressure alarm, number 1, I said, unkick the tube if there is kicking of the tube, empty water of the tube, turn the patient, ask the patient to cough or to take a deep breath, and then suction. High pressure alarm. Never forget, high pressure alarm is triggered by increased resistance to airflow. Now, what about low pressure alarm? Low pressure alarm. Low pressure alarm are always triggered by decrease in resistance. Low pressure alarm are triggered by decrease in resistance. Now, this can be caused by so many factors, which means if you hear low pressure alarm, you should be looking out for the following. Number 1, main tubing disconnection. Could it be that the tubings are disconnected? 2, probably there is CO2 oxygen sensor tube is disconnected, meaning you need to check for the oxygen sensor whether it is disconnected. Now, it could also be the fact that in both cases, what do? Reconnect the tubings. You need to reconnect the tubings. At that point, reconnect the tubing, and when you connect the tubing, while you try to reconnect the tubing, you ensure you bag the patient, meaning you try to elbow bag the patient, try to be giving oxygen to the patient, and then call the respiratory therapist. Low pressure alarm are triggered due to decrease in resistance, and this could be as a result of a disconnection somewhere. So that is what it means. Now, if you look at this picture, you're going to see an overview of what I said. High pressure alarm, which means it could be a result of kicking of the tube. We have client who is coughing, the gargling, bronchospasm, fighting the ventilator. It could be endotracheal tube obstruction. It could be kicking of the tube. It could be increased secretion, thick secretion, water in the ventilator, right? Just like we explained. This could be things that can trigger the high pressure alarm. What about low pressure alarm? We say pressure in the circuit is low. That ventilator may be set too high or too low. Now the question is this: if ventilator is too high or too low, what are we looking at for? Now, setting is too high, it means that the patient is overventilating. If the setting of the pressure, if the ventilator is set too high, at that point the patient is overventilating at that point. Meaning too much oxygen is going into the lungs. And when too much oxygen is going to lungs, it's going to drive out carbon dioxide. And when carbon dioxide level is reduced in the lungs, it's going to result in what we call respiratory alkalosis. Why? Because of the fact that carbon dioxide is acidic in nature. So when you have too much oxygen, you have reduced carbon dioxide, making the blood to become alkaline. Because remember we say that the carbon dioxide is acidic in nature. For the fact that it's acidic in nature, it means that we have reduced carbon dioxide by the time you hyperventilate. So setting the machine too high will result in respiratory alkalosis. What are the signs? The patient will be panting for air. 2, it's possible that the ventilator could be set too low. And when it is too low, it means that the patient is underventilating, or his patient is being underventilated. And when there is underventilated, it means that you're going to have more carbon dioxide in the blood or in the lungs. Mind you, we say carbon dioxide is acidic in nature. So when you underventilate, it means that you're having more retained carbon dioxide in the blood. And we have more retained carbon dioxide in the blood. It means that the patient will be having too much acid in the blood, resulting in what we call respiratory acidosis. So that is for that. And these are the things I want us to look at before we turn over to the question. So going to the question we asked, the first question says, a physician wants to wean a patient off ventilator in the morning. At 6 a.m., the ABG says respiratory acidosis. What would you do next? Respiratory acidosis, which means you have too much acid in the blood. The patient is on ventilator. The doctor wants to remove the ventilator at 6 a.m. However, the ABG says that the patient is having respiratory acidosis, too much carbon dioxide in the blood. It means that the patient is not fit to remove the ventilator, because at that point you still have too much carbon dioxide. The question is, what should you do next? Number 1 says, remove the ventilator as ordered by the doctor. Is that the best thing to do when there is too much carbon dioxide in the blood? Of course not. Let's hold on and move on to number 2. Number B says, notify the doctor that patient is not ready to be weaned off ventilator. Is that the best thing to do, even though you'll be giving the order? Let's hold on to this number and move to number 3, or the C. Continue to monitor the patient. Why continue to monitor the patient? Is that the best thing to do? Of course not. Number D says, check the machine if everything is okay. Now, acidosis means too much carbon dioxide still present in the blood. From what we said previously, it therefore means that at this point, the patient is not ready to be weaned off from the ventilator. So the best thing to do at this point is to tell the doctor that the patient is not ready to be weaned off ventilator because he still has too much carbon dioxide in the blood. So answer to number 1 question is B. Notify the doctor that patient is not ready to be weaned off ventilator. No. Moving on, let's go to number 2. Number 2 question says, ICU nurse is caring for a sedated client on the ventilator. The ventilator alarm is beeping persistently for low pressure despite the fact that the client is calm and has stable vitals. What is the most appropriate action for the nurse to take? Low pressure. Low pressure. Remember we say under low pressure, for the fact that the patient is having low pressure alarm, it means that something has gone wrong, meaning there is disconnection somewhere. So what should you do? You check out for any form of disconnection. So that is the rule. So let's go to the option. Number 1, suction the air, suction secretions. Remember, suctioning secretion means that there is high pressure alarm. But the question is saying low pressure alarm. So number A is out of the way. Number 2, check the tubing for holes. Yes, it's possible we should check the tubing for hole because low pressure alarm signify that there is a leakage somewhere. Let's hold on to number B and move on to number C. Number C says call respiratory therapy. Is that the first thing we should do? Having hearing or having to hear low pressure alarm, is that the first thing to do? Of course not. You need to check first to know what to do before you call the therapy. Next, continue to monitor the patient. Of course, you cannot continue to monitor at this point. So the first thing to do is low pressure alarm. Mind you, low pressure means something has gone wrong in terms of the tube. There's an obstruction, there is disconnection somewhere. So the first thing you need to do is to check the tubing for hole. If there is hole or there is disconnection. So answer to number 2 is B. Check the tubing for holes. Now let's move on to number 3. Number 3 says a physician wants to wean a patient off ventilator in the morning. At 6 a.m., the ABG says respiratory alkalosis. What would you do next? Mind you, number 3 is the opposite of number 1. The difference is number 1 says acidosis, number 3 says alkalosis. Mind you, we say alkalosis simply means reduce carbon dioxide in the blood. And when there's reduced carbon dioxide in the blood, it means that the blood become more of base and not acid. Remember, we say CO2 is acidic in nature. So if you have reduced carbon dioxide in the blood because of the fact that the patient is on ABG, it means that the individual is okay. It means that the individual can stay off from the machine, because for him to have reduced carbon dioxide, we are not supposed to have too much carbon dioxide in the blood. Instead, more oxygen, because the body needs more oxygen than carbon dioxide. So what should we do if we have reduced carbon dioxide in the blood? That's what the question is asking us. Number 1, remove the ventilator as ordered by the doctor. Is that the first thing we should do? Yes, we can remove it because the patient is stable. Respiratory alkalosis means it's okay. Let's hold on to number 1 and number A and move on to number B. Notify the doctor that patient is not ready to be weaned off ventilator. We cannot tell the doctor is not ready because it means that the patient is okay. Respiratory alkalosis means the patient is okay. C, continue to monitor the patient. There is no need to monitor the patient because respiratory alkalosis means the patient is okay at this point. D, check the machine if everything is okay. Of course, everything is okay with the machine. So at this point, the patient is ready to be weaned off from the machine. So the best option to number 3 is A. Remove the ventilator as ordered by the doctor. I guess you'll find this question useful to you. I want you to hit the like button and share for others to notify it, and then for others to enjoy it. I'm going to drop a question after, and I want you to look at the question, analyze it, and drop your answer in the comment section. Thank you, and then God bless you.